So very good afternoon to all of you. And today we are here to discuss this webinar, the webinar of GTG number 67, Management of Endometrial Hyperplasia, which is the most important aspect in gynae from exam point of view, as well as the recent TOG, as you all requested me to do the recent TOG. So I put TOG 2022. This is the first volume, and the topic is post-coital bleeding. Post-coital bleeding as such is always an important topic, like postmenopausal bleeding. It's a small topic, and you can correlate it with the contraception. Like in contraception, you must have read the unscheduled bleeding with contraception. So it will, when you read it, it will look to you similar like that. You can relate that with this. So we will go through that, and we will correlate with the what we have read already. So we get to know what difference in this new talk. So that way it helps us in understanding the difference and memorizing that well. So hopefully after this webinar, you will feel very confident about these two topics. And as well as we will discuss the questions from MRCOG question bank. So that will really help you all to understand the topic well. So you all know me, I'm Dr. Shweta Santhalia. I am course director and mentor at MRCOG. And I wish you all very best in your preparation and your journey of MRCOG. So let's start the webinar. I welcome you all on behalf of MRCOG, Dr. Shilpa, Dr. Sadia, Dr. Gopa, Dr. Asha, Dr. Angela, Dr. Rehana. I'm very happy you all are here, and let's start our discussion. So let us first discuss the talk. So if you see, this is 2022 talk of January volume. Let us first discuss this, and then we will discuss the GTG, and then followed by questions. So if you see post-coital bleeding, this is, we usually see the patient coming to our clinic with post-coital bleeding. So do you think that all of them are having cancer? Because we are worried about cancer. Whenever we think about post-coital bleeding, we think about cervical cancer. Am I right? What do you think? What comes in your mind when you listen about post-coital bleeding? Do you think about cancer, or do you think about something else?
Yes, ma'am. There may be a polyp also, cervical polyp.
Very good.
In young women, this is also a most common cause of post-coital bleeding.
Yes, very good. So when you see in the clinic, most of the time women will be coming to you with the complaint of post-coital bleeding, contact bleeding. Sometimes they will tell you that they are bleeding just like that. So there could be many presentation of bleeding, out of which post-coital bleeding is something we are really worried about, because sometimes it could be related to cervical cancer, and we want to rule out that in a patient presenting with post-coital bleeding. If you see, it is a common symptom in gynecological patient, and you will see up to 9% of the women. It's not less, up to 9%. So almost, if you see 1 in 10 women coming to your clinic can have post-coital bleeding. So post-coital bleeding, then we should understand the causes, because most of the time it will be benign causes. Most of the time it is not because of cervical cancer, though that is the most worrisome thing for us. So we want to rule out that. That is our priority. But it is not always because of cancer. Most of the time it is because of the benign condition. So if you see, it is a non-menstrual bleeding or spotting occurring immediately after sexual intercourse. Coital means coitus, means sexual intercourse. So after sexual intercourse, you are getting this bleeding, then you label it post-coital bleeding. And you want to rule out the cancer in such scenario. Now, if you see, this is also known as contact bleeding. So anything raw area, when it comes in contact, like whenever a woman is having intercourse and it is coming in contact with any raw area, either in the vagina or vulva or cervix, will lead to bleeding. So we will get a clear concept of how postcoital bleeding is a contact bleeding, and we should think about all the local causes, and we should rule out all the benign causes And we should definitely rule out the cervical cancer, because that is what we are worried of, because that can cost us too much. So if you see the causes, there are usually benign causes, then there comes the infection, then vulval, malignancy, and other causes. So if you see, if you will start from vulva and then go beyond. So if you start from vulva, you will see there could be some local cause of vulva, right? There could be vulval lichen sclerosis, lichen planus, or vulval infection like candidiasis, or anything in the vulva which make the vulva vulnerable to bleed by touch. So whenever the woman is having intercourse, the vulva will also come in contact, so it can bleed. So it could be related to vulval condition. Then we will go forward and then we will go to vagina. So it could be related to vagina. So in vagina, you can have vulvovaginitis. You can have infection, like simple infection like candidiasis, trichomoniasis. That can also lead to postcoital bleeding, because now the vagina is weak. Now the vagina is infected. It is at risk of bleeding. So vulvovaginitis is the another cause. Then vulva, vagina, and then comes the cervix. So cervicitis also, because of the chlamydia or gonorrhea, can lead to postcoital bleeding. Then you go forward in the uterus, there could be endometritis. So endometritis, they say that it is rare to present only as postcoital bleeding. It will usually present as intermenstrual bleeding with postcoital bleeding. So endometritis, they will usually not give you an exam simply just as postcoital bleeding. They will give you in combination with intermenstrual bleeding. So mainly you have to worry about vulva, vagina, and cervix, the local things there. In the vulva, as I told you, there could be infection, there could be a pre-malignant lesion in vulva, the same way in vagina. There could be infection, pre-malignant lesion. And then when you come to cervix, the most common things we see is cervical ectropion. So cervical ectropion, cervical endometrial polyp, these also sometimes will present as postcoital bleeding, because ectropion is also a raw area. So it can bleed after intercourse. Polyp is also fragile and tend to bleed, so it will bleed with intercourse. The other thing commonly seen in postmenopausal women will be urogenital atrophy. Postmenopausal women usually have urogenital atrophy because of the lack of estrogen. So their vagina is weak. There, all the pelvic tissue will become weak and fragile for a postmenopausal woman because estrogen is not there. So this also can lead to postcoital bleeding. So these are some benign and common things you have to always think about. Always rule out infection, always rule out pregnancy, the contraception related causes. These are our main goal, to rule out this. And then the cancer, obviously we are always worried about the cancer. Then there could be some problems, like she's having bleeding disorder, she's taking anticoagulants because of some reason. In children and all, you might see foreign bodies sometimes, not exactly children means not exactly less than 14 or something, who are sexually active and who are unaware of things properly. They might sometimes forgotten pessary will also be there. So anything foreign body can also be there sometimes. And the last thing is the abuse. And if you see in UK, they are very sensitive about abuse. So there could be sexual abuse also. So all these things you have to keep in mind whenever you are seeing a patient of postcoital bleeding, all benign as well as the malignancy. So if you see, it typically arises from contact with the lesion on cervix, vagina, or vulva. These are our three main targets. And then if you see endometrial, as I told you, in combination with intermenstrual bleeding, it will present. And most of the women have benign condition, we already discussed. Now, how you will assess. So for assessment, if you see, if I give you like this, like history exam, if you read in the TOG, it's written one by one. So once you read the second thing, you forget the first thing. So if you see it like this, a good presentation really makes a difference. So you will never forget it. So history, examination, and investigation. What all? How you will assess her, how you will investigate her, what all things you will keep in mind when you are taking the history is very important. So what you will ask in the history? As I told you, we are focusing mainly on three things: pregnancy, infection, and the third thing, what I told you, in a reproductive age group women, if she comes with postcoital bleeding, you're worried about pregnancy, infection, and what is the third thing?
Contraception.
Very good. Contraception.
OC.
And the most important thing is cancer, which we want to rule out. So these four will be our goal. To ask her the history about contraception, because oral contraceptive pills can also lead to bleeding, postcoital bleeding, because of ectropion. The OCs can lead to ectropion, and that can lead to bleeding. So contraception is also important. Pregnancy, that's why the menstrual history is also important. And you want to rule out the infection, that's why the sexual history is also important. And then our most important, cervical screening, because we want to rule out the cancer. So this will be, the whole topic will be revolving around these four things, right? So you have to ask her the history so that you will elicit all the risk factor, if she has anything, any probability, if she is a sexually active woman, multiple partners, something like that, so she can have STI. If she's a young woman, less than 25 years, always there is chances of STI. So STI very important for young women, less than 25 specifically. Whenever in exam, in question, they give you less than 25 years, means they want you to get attracted towards sexual infection. So always be careful about age in gynecology. In gynecological question, until unless you notice the age, you will not understand that what they are talking about. So age is very important. So sexual history, especially for less than 25, you suspect chlamydia. That is most common infection. And as I told you, her menstrual history, because she could be pregnant. She's in reproductive age group. She can be pregnant. You will ask her contraceptive history, because OCs are important. Then you will ask her about if she has been immunized with HPV, if she has previous any medical surgical illness, she's taking any medication, all these things. And her cervical screening is up to date or not. This is very important. So these all things you will ask in history. Then you will do the examination. So in examination, as I told you, our focus will be vulva, vagina, and cervix, right? Because we saw these are the local things which can lead to contact bleeding. So abdominal examination you will do to rule out PID. You might see some masses. Maybe she's having bleeding because of PID, because of tubo-ovarian mass, cervicitis, all combined. So abdominal examination, always in any gynae patient, you will do abdominal followed by local examination. So do your abdominal examination, then do your vulval examination. Very important to evaluate the vulva also. Sometimes when we are in clinic, we simply put the speculum and we don't notice much about vulva. So you should keep your eyes open for the vulval problems also. Because vulval lesion, if you see for RCOG exams, vulval lesion is really, really important. Vulval ulcer, all the vulval lesions, they are very keen to ask you. So you should know everything about vulva. So if you see the vulval skin, you might see some dermatitis, you might see some ulcer, excoriation, fissuring. All this could be simply because of candidiasis. So it's very important for you to evaluate the vulva, to look for it, if there is any chance of infection, if there is lichen sclerosis, lichen planus, if there is any VIN type of symptom, any disfigurement, anything, any scarring, anything, any piercing, FGM, trauma, anything can happen, which can lead to postcoital bleeding. So inspection of vulva, very, very important. And then you will put the speculum and evaluate the vagina. So in vagina, what do you want to see in the vagina? Again, you want to see if there is any atrophic changes for postmenopausal women. There could be injury in the vagina, laceration, because of forceful contact, or anything can happen. Some instrument or something they might have used, you don't know. There could be prolapse, which might have the raw area ulcer, which might bleed. Any ulcer in the vagina can bleed. And then again, the vaginal pre-malignant lesion and vaginal cancer in the which usually vaginal cancer will be seen in the posterior wall, posterior upper half. So the vagina is also very important. So don't think you are doing speculum examination only to look for cervix. First of all, see vulva, then see the vagina, then see the cervix. Very important. Now, if you see the cervix again, you want to look for cervix, how it is looking, is it healthy, unhealthy? Then you want to rule out ectropion because it is very common. You want to see for polyp if it is there. Then you want to see if it is unhealthy looking. If it is unhealthy looking, you're thinking about cervical infection, cervical CIN. It could be CIN. If you're seeing any fungating mass, any excessive discharge, it could be cervical cancer. So all in all, that all you want to see in cervix, any local thing you see there. As I told you, if it is a cancer, it will be very ulcerative, friable, very irregular mass. Means you know how malignancy look like. Malignancy never look like organized thing. So it will be something very ill-defined type of thing, friable tissue. So once you see the malignancy, you will never forget. So it's easy to understand that it is the tissue is very looking very vascular, very ugly, and all that things you can easily make out that that is definitely not healthy. So anytime if you see the unhealthy cervix, anytime if you see the unhealthy cervix, please, please, please never choose pap smear. Pap smear is not for unhealthy cervix. It's for healthy cervix. For unhealthy cervix like ectropion and all, you will do pap smear to rule out malignancy. That is a different thing before doing the conservative management. But whenever you see any mass or anything which make you think that it is cancer, then you will not choose pap smear for screening, because that is a screening test. Now you're seeing something, you're seeing an unhealthy cervix, then you have to refer her for further evaluation to a gynecologist which has interest in cervix. So you will escalate the matter. You are not going to do pap smear and sit with her to wait for the pap smear result, because that is for screening. Here you are seeing something which is significant. So you are not the right person. You will refer to the specialist and they will do the needful. Maybe they will simply do the biopsy or whatsoever, whatever good for the further management. But screening, cervical screening or pap smear is not for if you see anything looking like cancer. In that case, screening doesn't make sense. You are doing screening to diagnose CI and all, and you want to avoid them to develop the cancer. So that's an important aspect of cervical screening. So you did the examination, you finish your history, now you will do some investigation. Definitely nowadays, we don't leave the women just by history examination. We have to do the investigation. We should have something on paper, right? To negate something, to confirm the diagnosis. So all in all, we have to do some investigation. So what investigation we will do? First of all, anybody in reproductive age group, you have to do the pregnancy test, very important, because sometimes because of pregnancy, the cervix will be congested and she's not aware of pregnancy. Maybe she has a regular period, she's not aware of pregnancy. She'll come to you as complaint of postcoital bleeding. When you examine her, the cervix is looking bluish, you think it is pregnancy, or even otherwise you will do a pregnancy test because she might be pregnant. That's why the vascularity of cervix is more, that's why it is bleeding. So pregnancy test is very important, and even pregnancy can lead to ectropion. So pregnancy test is very important in reproductive age group. The same as amenorrhea. Whenever you get any reproductive age group women with amenorrhea, you will always do pregnancy test, right? So this is how you have to do. So you will do pregnancy test, and then what next? You want to rule out infection, right? So after pregnancy, you want to rule out infection, cervicitis. So what you will do? You will do vulvovaginal swab for NAT. NAT is nowadays the test of choice for most of the infection. So you will do the NAT, vulvovaginal swab. What you want to rule out by that? Can anybody tell me what you want to rule out by vulvovaginal swab?
Chlamydial infection.
Very good. So chlamydia, gonorrhea, all the infection which you can detect by the swab. So mainly chlamydia and gonorrhea is what you detect by vulvovaginal swab. Why you are worried more about chlamydia and gonorrhea? Because that lead to PID and further sequelae. It's like simple vaginitis is not going to harm the women's future life, but chlamydia and gonorrhea can affect her future life, her fertility and everything, all in all. So it's important for you to diagnose it and treat it to save her future fertility and to avoid future consequences of PID, tumors and all that thing. So that's why you're doing swab. You did the swab, you ruled out infection. Now, the other thing you want to look for is her screening test is up to date or not, right? Because these are our common causes. So screening test you will do, this will only apply to age 25-year or older, right? Cervical screening, when we'll cover cervical screening, we'll come to that in detail. But cervical screening is done for age 25 or older, not before that. So it's very important for you to understand that. If her interval of screening has been over, like 3 year up till 50 and after that 5 yearly, so if she has done more than 3 year back, you will repeat it. If she has done within 3 years, you will not repeat it. So that is how you will choose a cervical screen. Now, if the cervix is clinically normal, means you have not seen anything in the cervix, vagina, vulva, cervix, all are looking normal. Now what to do? You're not finding any cause for her postcoital bleeding. So what to do now? So in that scenario, you can do transvaginal ultrasound and endometrial biopsy with or without hysteroscopy. Why you're doing this? Can anybody tell me this?
To see the endometrial cavity, endocervical canal and endometrial cavity, and to rule out any local causes like
Yes.
polyps.
No. Yes. So any mass lesion to be very precise, whenever you do ultrasound, if you do a good ultrasound, you can see endometrial pathologies like endometrial polyp. There could be, you can sometimes see endometrial hyperplasia also, like it will look cystic spaces in the endometrium. So all that things you will get to know by ultrasound, as well as you will be able to evaluate the ovaries if she has any pathology, any endometrial pathology associated with ovarian pathology. So all in all, when you're not finding anything on your examination and local thing, you have to rely on the ultrasound. So you will do ultrasound, you will do pipil biopsy for sure, because you want to do the endometrial pathology rule out, means you have to have biopsy, because hypoplegia cannot always be diagnosed by ultrasound. The histopathological diagnosis. So you will take the biopsy, at least outpatient pipil biopsy. It's a simple thing, just like a thin refill sort of thing. It's a very thin thing which you can easily do in the OPD. So you take the simple biopsy, you will do the ultrasound, and if you think any focal lesion, any mass lesion, then you will do the hysteroscopy. This all you are doing to rule out endometrial pathology, because endometrium cannot be seen by naked eyes, right? So we have seen the three things which we could, and then if we didn't find anything in that, then we have to do the ultrasound and biopsy for the women to rule out the endometrial pathology. Am I clear about how you will assess a woman with postcoital bleeding now? Are you getting a picture that what could be the causes, how you have to ask the history, what are important things in history, and how to evaluate her? Okay, very good. Thank you, Rehana. Now, so we saw what all investigation we will do. Just to summarize here again by the chart, it's good that always we have some chart and pictorial presentation in the talk, which help us in remembering things in a better way. So postcoital bleeding, you will take the history, you will do the physical examination, you will take the swab. Here pregnancy test they have not mentioned, but in reproductive age group you have to do that. You will take the swab, you will do the screening test if not done. If it is abnormal cervix, now again here, as I told you, abnormal cervix means screening test doesn't make a sense, then you will do directly colposcopy. So you have to refer her to the specialist. So if abnormal looking cervix, you have to do urgent referral. So within 2 weeks referral is what you are going to do. Or if she has a symptom of cervical cancer, like unexplained postcoital bleeding, persistent discharge, mainly cervical cancer patient, I don't know if you have ever encountered with cervical cancer patient in your clinic, but believe me, it's the persistent discharge and it's the smell. Once they enter in your OPD, with the smell, that necrotic smell, that itself make you understand that you are dealing with cervical cancer patient, believe me. So they usually don't present with bleeding, but they usually present with discharge and bad smell because of necrosis. So that's the usual presentation of cervical cancer. So if she has a symptom of cervical cancer, or on examination you found the cervix abnormal, in all the situation, you have to urgently refer her within 2 weeks to the gynecologist with a special interest in cancer. And then they will evaluate, that will be a first step. And then if they think it is cervical cancer, or if they take the biopsy or whatsoever, they will refer to the oncologist accordingly. So this is how you have to take it very seriously, abnormal looking cervix as well as the symptoms. So we are clear now that clinically abnormal cervix, you will directly refer them for colposcopy, no role of screening. Screening is for normal people, not for abnormal things. Now, if everything is normal and there is persistent postcoital bleed and coexisting intermenstrual bleed, as I told you, usually for endometrial, they will give you intermenstrual bleed also. Because usually endometrial things will not present as postcoital bleed, but combination. So if they give you this, then you will consider further test for her. And then as I told you that violence, you have to rule out. So they have come up with this partner violence question, which is hard question. You don't have to memorize it by heart. Just keep an idea that there is something new terminology has come, like HARP question for partner violence. So just a name is enough for this thing. So this is how you will investigate her and refer her to the secondary care. Now, how you will manage a cervical ectropion? You saw, you diagnosed already whatever your problem of the women with post-coital bleeding, you have diagnosed. Now you want to treat her, right? So for management, if you see cervical ectropion, it looks exactly like this. There will be like this roundish, this oval, this raw area of redness, and this will be whitish pinkish, and this will be reddish. So darker color than the surrounding area is the ectropion. If you see, this is the animated picture. If you see really, it is a big ectropion. It could be small like this around the external os, or it could be big like this. So this is a big picture, means big ectropion, where you can see this is pinkish whitish and this is reddish. So this is how ectropion look like. Now, if you see how you'll manage it, so first of all, you have to understand what could be the reason. So you will treat accordingly. So if you see the reason, most commonly, if you see, it could be because of physiological thing. Like it could be seen after menarche, it could be seen in pregnancy, it could be seen with oral contraceptive pills. So it's most of the time it is benign. But if it is chronic, chronically, if somebody is having ectropion and it is not healing and it is becoming bigger and more discharges and again chronic infection, HPV infection, and then it can turn out to be CIN. So you're worried for ectropion. It is not like because it is a raw area ultimately. So you may grab infection from here, any kind of infection. So you're worried. How it usually present? It will present with increased discharge. Most of the time they present with more discharge, that I'm getting unusual discharge, though I'm having no itching, no smell, but I'm having too much discharge, which is bothering me. Or they will come with post-coital bleeding, or both. Post-coital bleeding, because this is a raw area. If the while intercourse the penis is touching here, obviously she will have a bleeding. So, or sometimes simply on examination you will find it and they are totally asymptomatic. So this is how they present. These are the benign region. So obviously, if she's on oral contraceptive pill because of which she has ectropion, so you have to change the pills to progesterone only. If she accept, you will say that because it is because of COC, so if you want, I will change you to progesterone. That might help with your symptom. So that is one treatment. Otherwise, the other treatment will be if it is too much persistent and troubling the women, you can offer them cryocautery or diathermy to the cervix. Because it's a benign lesion. Cryocautery means by the cold, by the nitrous oxide, by the ice, that you are burning it. And diathermy means by the heat you are burning it. So ultimate your goal is to burn it, and then the normal epithelium will come over it, and then there will be no symptom. So this what will be your treatment for her. Can I ask you, before doing cryocauterization, what is the must investigation you should do for any women with ectropion?
Pap smear.
Very good. You have to do pap smear to rule out cancer before doing burning that area, because you are not taking biopsy from there. You're burning that area by ice or by a diathermy. So you don't know if there is cancer or not until unless you do the smear. So smear is very important, ruling out the malignancy. Whenever you are doing any conservative management and you are not taking the biopsy, pap smear become really, really important. So here it's a prerequisite that you take the smear. Clear, all of you? Okay. Now, cervical polyp. How the polyp look like? If you see, this is the cervix, this is the polyp. This exactly look like this, believe me. Small polyp, and this is the small and large two polyps. So if you see in clinical scenario, it looks like this. So how red it is? You see the normal cervix, pinkish whitish. This is the normal cervix, and this is the polyp, very red, very angry looking, right? So this is how the polyp look like. Now, this polyp, sometimes it is cervical polyp, and sometimes the endometrial polyp can also prolapse through the cervix. So it could be both. It could be endometrial as well as it could be cervical. Both ways, both possibilities are there. But most of the time it is cervical. So this, you see, if you see, it is so vascular. It is so red and angry looking. that definitely with intercourse it is going to bleed. Even if you touch the cervix to take the pap smear or something, it is going to bleed. The same way, if you see here, the ectropion, this also bleed. When you take the pap smear, it will bleed. So don't think that you are dealing with cancer, because this is a raw area. This is going to bleed with pap smear, but this is not cancer. So you have to screen it. So here's the polyp. It looks like this. How you are going to treat it? Usually, because they are friable, they will bleed on touch, and it is most frequently present in perimenopausal and postmenopausal women. Why? Because they have the hormonal imbalance, because their periods are stopped after postmenopause, the periods have stopped, and again the hormone imbalance. So all that things, it happens usually because of the inflammation or atypical response to hormone. So chronic inflammation can also lead to polyp. So you will see the polyp, what you will do. If it is symptomatic, very important to understand if it is symptomatic, and if you see abnormal cervical cytology, that means the pap smear is abnormal. In that case, you have to remove it and send it for lab to rule out the malignancy, right? So symptomatic polyp means you're worried, because what they say, once you go through the, I think 2012 TOG of polyp, endometrial and cervical polyp, if you see that TOG, you will get to know that if they are asymptomatic polyp, the chances of malignancy is less. If they are symptomatic polyp, the chances of malignancy is more, almost 3 times, or I think more, even more. So symptomatic polyps are something you're worried about. So symptomatic polyp or coexisting abnormal pap smear, you are going to evaluate that further. So you will take it out and send it for histopathology. Symptomatic polyps sometimes can be associated with endometrial polyp and hyperplasia, because any hormonal imbalance means cervix is not the only target. The endometrium is also the target, right? Endometrium will be the first target always with the abnormal hormones or abnormal sensitivity or whatsoever. So definitely you have to think about endometrial polyp and hyperplasia also. If there is a cervical polyp, there could be endometrial polyp. And this is what we do in our clinical practice. Whenever we see a cervical polyp, we just don't take it out and send it for biopsy. Yes, sometimes if it is very simple to take it from OPD, we do that. Otherwise, if we are doing hysteroscopic removal or in theater removal, we always do hysteroscopy to check inside the uterus also. So always keep in mind that symptomatic polyps can be associated with endometrial polyp and hyperplasia. So you should have a look of uterus also. This is just a tip of iceberg. There could be a bigger problem sitting up. So it's important for you to do the hysteroscopy. So they say that 55% of the women in postmenopausal women who has cervical polyp, means more than a half, will have endometrial abnormality. So it's very important to do hysteroscopy and sampling. So in postmenopausal women, if you see a cervical polyp, don't think that you will just simply take it there and leave it. Because in postmenopausal, you're more worried about endometrial problems, right? If there is endometrial thickness more, or a hyperplasia or atypia or whatsoever, you're more worried in postmenopausal women. So whenever you see a postmenopausal woman with cervical polyp, you are going to do hysteroscopy and sampling for sure, because more than half of the women has endometrial abnormality. Am I clear about this polyp now? That how you will deal postmenopausal women polyp differently than the premenopausal. Because postmenopausal, even the polyp has more chances of malignancy than premenopausal or perimenopausal. Clear, all of you? Okay, great. Now, so we ruled out, we have seen cervical ectropion, the most common thing we see in clinics for postcoital bleeding. Then we have ruled out cervical polyp. Now, cervicitis, endometritis, PID. As I told you, less than 25, always think about infection. Okay. And if they have the risk factor like multiple sexual partners and all that things, if they are not using barrier contraception and all that things are, and their behavior multiple man to men and different kind of sexes, so all that things make them more vulnerable for infection. So PID is always a thing you have to rule out whenever you find any abnormality in the bleeding and things like that. So you are worried about PID. So for PID, you will do this all anyways. We will be covered in the sexual sexual session. But if you see briefly for PID outpatient, you give the ceftriaxone nowadays. This is a change. Ceftriaxone 1 gram is for gonorrhea, right? So you will give 1 dose for gonorrhea, and this doxy and metro you are giving for chlamydia. So this is what you will give her for 14 days. The difference between PID and cervicitis is, in PID you give for 14 days, 2 weeks, while in cervicitis you give only for 1 week. That is the difference. If you keep her inpatient, means her condition is more serious, she is more severe presentation, fever and all that things, then you will give her 2 gram ceftriaxone and IV or oral doxy till 24 hours after improvement of symptoms, and then again oral for 14 days. So this is how you will manage your PID. Now, as I told you, chlamydia is the commonest bacterial STI. As I told you, this is mostly in age less than 25, up till 7%. So quite high, isn't it? Age of 25, under the age of 25, 7%, quite high. So please don't forget chlamydia whenever you want to talk about any abnormal bleeding and cervicitis. So how you will treat chlamydia? You will give her azithromycin. This is also changed in the recent guideline. Don't forget, always the recent change are more important for exam. So azithromycin 1 gram orally. Earlier it was single dose. Now they say single dose not enough. So single dose of 1 gram followed by 500 milligram once daily for 2 days. So now it is 3 days treatment in place of single dose. 1 gram start followed by 500 milligram daily for 2 days. So total it will be 2 gram in over the 3 days. So you have to remember that azithromycin, no more single dose for chlamydia. And then comes the doxy. As I told you, either azithro or doxy. So if you give doxy, it will be 7 days course for the doxy for chlamydia. What you will give for gonorrhea? First line will be 1 gram ceftriaxone IM. Why this one? Why all other azithromycin and everything is removed from gonorrhea treatment? Because the gonorrhea is becoming drug resistant. All the drug, earlier Ciplox was approved for gonorrhea. Now they say that gonorrhea is becoming resistant to all the antibiotic. That's why ceftriaxone 1 gram IM as a single dose is the first line for gonorrhea now. And always after gonorrhea, you have to do the test of cure because, as I told you, drug resistance. So you want to make sure that you have treated her well. So you have to do the test of cure always after gonorrhea treatment. So this is important. Now, so you have ruled out infection, local problem like polyp and ectropion. Now we'll talk about vulval and vaginal lesion. What could happen in vulva and vagina? Just benign things we will be talking first. So we talk about urogenital atrophy in postmenopausal women. What will be the treatment and what will be the examination finding? So if you examine her, the vagina will be very pale looking, dry. So pale and dry, this is both postmenopausal. And how you will treat it? So you will give her moisturizer because it is dry. So give her moisturizer, lubricants, topical estrogen because all this atrophy because of lack of estrogen. So give her topical estrogen, DHEA and ospemifene. This ospemifene is becoming more famous nowadays. Don't forget this drug because even we have got a new TOG on 2020 January about sexual dysfunction. Earlier, they used to ask you about vulvodynia. So now sexual dysfunction of this one. 2022, this January 1st thing. So this drug is also important. And then laser at the last resort. So atrophy is something you are worried about. And then in vulva, there could be dermatosis. We already talked about. Give me a minute. There is some connection error it is showing. Okay. So vulval dermatosis, we talk about lichen planus, sclerosis, contact dermatitis. So all this could happen whenever you think that it could be VIN or anything suspicious, you are going to take the biopsy. Vulval biopsy, believe me, this is the most favorite question of RCOG. Vulval biopsy, how you will took, when you will took, how, when, where, everything. So vulval biopsy should be considered if there are pigmented lesion, very important, pigmented lesion, ulcerated lesion, eroded areas, or if the patient failed to respond to the treatment. Like for lichen sclerosis, you have given the steroid treatment, she didn't respond. So there could be malignancy, right? If she's not responding to the usual treatment of a benign thing, there could be cancer. So you have to think about that. So whenever a patient doesn't respond to the treatment, or if you see the pigmented word very important. If you see any pigmented lesion, you have to be suspicious. So pigmented lesion in the vulva, ulcerated, eroded area is a bad thing. So ulcerated, eroded, ulcer not healing, that is also a sign of bad thing. So all these areas you are going to take the biopsy, and you all know that you will take it by punch biopsy, including the normal vagina vulval tissue. So you will not take only the abnormal area, you will take the normal area. So edge, incisional biopsy from the edge, punch biopsy, all these things for vulval biopsy whenever you want to take it. If you see lichen sclerosis, they have mentioned that it leads to 4 to 6.7% squamous cell cancer of the vulva. So the percentage has changed now, 4 to 6.7%. So please don't forget it. That's why lichen sclerosis, you do annual review. You don't leave them, you review them. So annual review is what you have to do for them when you treat them by steroid. And look for the symptom. If symptom is not resolving, you have to take biopsy and make sure that she improve either, or if she is not improving, you rule out the malignancy at least. So this is how you deal with vulval vaginal problems. Now cancers, management of pre-malignant and malignant lesion. Again, VIN, CIN, VAIN, vaginal pre-malignant and malignant. So cervical cancer, what is our main thing, what we are worrying from the beginning till now is cervical cancer, right? Because that is usually out of all, that is the one which present with mostly post-coital bleeding. So CIN and cancer, if you see how much you will see CIN cancer in a women with post-coital bleeding will be 3 to 18%. Why all this figure I'm highlighting? You should keep an idea. Yes, I understand that every figure you cannot memorize, but if any new thing comes, they want you to be aware of what is the percentage, like if it is less than 20, less than 10, less than 50, more than 50. So at least make yourself aware of this. So if you see, if you round it out, average it out, it will come around 10%, right? 18 plus 3, 21. So it will come around 10%. And if you see the post-coital bleeding in women, it is 9%. So approximately 1 in 10 is what you can remember. So if you see the prevalence, it is 3 to 18%. So definitely it's worth evaluating them and ruling out the cancer. They've clearly mentioned that nowadays this immunization program, which has a Gardasil 2 doses, they give 12 to 13-year girl as well as boys. So nowadays the immunization program is also for boys. VIN, VAIN and cancer. Again, rarely it will be the presenting symptom for the cancer, but you want to rule out. So you will see clinically, you will evaluate, and accordingly you will take the biopsy. Whenever you take any biopsy, supposedly you are thinking it is benign lesion, it's non-healing, but it's mostly benign or whatsoever, or you think it is a suspicious lesion, it can lead to cancer. So whenever you see a suspicious lesion, you will not wait for the biopsy result to confirm it and then send her to the specialist. You will immediately send her to a specialist. You take the biopsy, no problem. You wait for the result is awaited, no problem. But you will refer. Urgent referral, the same. 2 weeks referral is what you have to do, because there in UK, the appointment system, getting the referral, all that things take time. So they don't want to waste time just simply sitting, getting the result and then escalating it. Better to escalate it from the beginning. And let her have the appointment. So by the time she meet the specialist, they already have the report, or even if not, the expert eyes has already seen the patient clinically. So that is what the purpose of all this urgent referral and everything. So if you are strongly suspecting, you will do the urgent referral and you will not wait for the biopsy result. Am I clear about this? Am I clear about all the aspect of post-coital bleeding? This is the last slide for post-coital bleeding. Great. So shall I ask some questions then? Okay, great. So let me ask some question then. What all you will suspect and how you will evaluate. This is what we have learned, right? Because management is different for everything. So how you will investigate a 35-year-old woman presenting to you with postcoital bleeding. Supposedly, you have received a patient, 35-year-old, with postcoital bleeding in your clinic. So what you will ask, how you will examine, and what you are going to do. Tell me that. What all you keep in your mind to take her history, and what all you keep in your mind while doing examination. Yes, come on. Anybody can open their mic and speak up.
We can ask them about their pap smear, whether they have been taking regularly. Then we can ask them about whether they have intermenstrual bleeding
Very
accompanying
good.
the postcoital bleeding. Then
Why you are asking
any
her about intermenstrual
contraception,
bleeding?
because it can be endometrial pathology.
Very good. And you ruled out cervical screening. What else you will do?
You'll ask them about contraception.
Very good. What else?
Pregnancy.
Very nice. First is pregnancy. What else? One more left.
Sexual history, ma'am.
Sexual history. So these are the things.
Pregnancy.
Pregnancy, infection, contraception, cancer. Right? Pregnancy, infection, cancer, and contraception. So if you remember it in a short form, PICC. Right? So this is what you keep in your mind. You took the history. Now, examination. What all you will examine and what you are keeping in your mind.
We'll examine the vulva, then the vagina, and then the cervix.
So what all you
So
will see
we
in
look for
vulva, vagina, and cervix.
pigmented lesions on the vulva,
Very good.
ulcerative lesions, any dermatitis,
Very good.
any
If I see,
urogenital atrophy.
wait. She's a 35-year-old only, Dr. Gopa. So if I
Yeah,
see fissuring and excoriation on the vulva and red-looking vulva, what I should think of? And itching also. She's complaining of itching.
candidiasis.
Very good. So candidiasis, simple candidiasis can also present like this. Very good. So you looked for candidiasis, vulval things. Then you went ahead and examined the vagina. So what you will see in the vagina in a 35-year-old woman? What could you see?
You can see for ulceration, you can see for tears, and infection, candidial infection can be there.
Yes, so vaginitis is something. Vaginitis is what you usually get, right, in your clinic?
Yeah.
Vaginitis, like they will come with, I'm having excessive discharge and smell. It's a simple vaginitis. So that can also lead to postcoital bleeding. Very good. So you examined the vagina, you ruled out infection. Now you went to cervix. What you'll see in cervix?
So for any infection, cervicitis, polyps, whether the polyp is pedunculated or sessile, and if it's sessile, it's mostly on the cervix. If it's pedunculated, it may be a endometrial polyp, which is extruding from the cervix, and whether it's bleeding on touch.
Very good. What else? You saw polyp, you saw infection, and what else? The most common thing.
Any growth,
Ectropion, ma'am.
Yes, any growth. Very good. Ectropion, our benign. So these all things you will see, and if she has intermenstrual bleeding and you didn't find anything locally, you want to evaluate the uterus, so you
do hysteroscopy,
will do the ultrasound and evaluate the uterus, and if you find any mass lesion in ultrasound, then hysteroscopy. Or either you will find any mass lesion and difficulty, you will do hysteroscopy. Or if you see a cervical polyp in a postmenopausal woman, you will do hysteroscopy because you want to rule out endometrial polyp or hypoplegia in that women. Am I clear now? Shall we move ahead? Are you clear about postcoital bleeding now? Very good.
Yes.
So we will move ahead. Before solving the question and going to the GTG, I'm very happy that RCOG has announced about the September course. So I will just take you through what course we are offering for September by MRCOG. So RCOG has already the students who have mailed them already, they have told about September course, and it's a very good thing actually, because sometimes you don't get booking and you get distressed. So hopefully this time all the students will get booking. So they are preferring deferred candidate first, so that is also a very good move from them. So hopefully all the backlog will finish in this July and September, so all the fresh candidate can try for January like that. So nobody will be disheartened because of no booking. Believe me, when last time in last batch our student didn't get booking, we really got disheartened. Right, Rehana, I'm right or wrong? So it's very important that you get booking. To pass the exam, first of all, you have to give the exam. So I'm happy that they have come up with a September course. So as September is only 4 months down the line, so yes, I know. So only 4 months left, 4 months or 4.5 months, maybe according to the date, whatever date they will announce in September. So this is the right time for us to start for September. If any of you has not gone through the introductory session where we covered assisted vaginal birth and amenorrhea, if you have any doubt how to start your preparation or how to boost your preparation, you can go through this presentation in the YouTube channel. It has all the details of what all you have to do with your preparation. Key to success, we all know it's a hard work as well as smart work, right? Prioritization, dedication, determination from both the side, and consistent effort is what we need. We have to have targeted approach, every day little effort. Always I tell to all my students, each day little effort. Please don't do backlogs. Don't keep backlog. Every day little thing if you do, at the end you will be having nothing, no backlog. Daily discussion, daily question practice, right balance of reading and solving question is really important to ace this difficult exam. So if you think you need a help, you should choose your mentor from the beginning rather than at the end moment. How course help you all know that it will help you with the schedule, notes. It's easy now because you don't have to make the notes. Read 3 times and making a notes is a big task itself. So with the course, you get the notes. So you only have to note down what you have to memorize. You cannot remember in listening, that you can make your notes. So that helps. You get all the material in advance 1 week prior to your session. You get everything what you have to read. So you're prepared for the session. Once you listen in the session, you will remember it really well. You get a group to study, all are doing with the same pace as you are doing. So you think you are not alone. You never feel left alone. So that way you feel you are moving together. So that's a strength. That's a big strength actually. You can revise at your convenience because you have the recording. You can listen it 10 times, 20 times, as many times you want. If you feel one module of yours is weak, you can revise it again and again. And it helps you in boosting your confidence. And even before exam, when you feel last 1 month, you feel really low, you think, am I remembering everything? This is what in your mind. Actually, if your preparation is good, you are remembering everything in exam. But before 1 month, we all panic, right? We all before exam, we panic. So if you have that simply lying down and listening that recording, that will soothe you. You know that you remember things. The other important aspect is balance of reading and question solving. This is really, really important. The job is half done only by having clear concept. Ultimately, you have to solve the question because exam is question. You have to solve the question because you have to give exam in questions. You don't have to write them. So question solving, how they twist the question, how they confuse you, all that, until unless the question solving is done, it's difficult. So you have to keep a balance. Don't keep reading, keep making notes and no question solving. Every day, 2-hour reading, 2-hour question solving is what you should do. We do have question answer sessions as well as daily quizzes in the group that helps in student motivating in solving the question, as well as the mocks which really help them in evaluating their self. So this is how a course help in your preparation. For us, every student matters. We really, why I'm teaching in small group, because I don't want to have 50 or 100 students and I don't know even their names. I want to have a personal connect with the student and I really feel for them. I don't, if somebody doesn't come for the session or if they are constantly not showing up for the quiz or something, I keep touching them at private. Why? Because I want them to be doing daily little. At the end, then they will lose it. They will lose confidence, which I don't want. So for me, every student matters, and I don't believe in big groups. That's why we teach in small group, because every student can learn in a different way, different pace. So one-to-one care is what you need. So this is how the schedule is provided to you in the course, as well as the material in the beginning. And this is how your preparation ladder go, where in the last 1 month, you shouldn't read any new things. Any new thing shouldn't be read in the last 1 month, and your preparation should be at least 3 revision, at least 3. It could be more, but at least 3, but with question solving. So please be careful about that. These are all our Jan students' feedback, which is very near to my heart. And these are the success story of Jan students, which is really overwhelming response of what they have written, the beautiful words written by them, that how some specific topic like teaching ethics, clinical governance helped them, and how they got clear concept, how by pushing them to do question help them, the summaries help them, how they got a strong base and strong concept. And definitely it is going to help you in your part 3 also. This is our present running batch feedback. If you see, they are happy with the pop quizzes, they are happy with revising, they can revise as they want at their convenience. They really like the sessions, and they really, by question practice, they feel good about it. Mocks, they feel good about it. And if you see my slides, it's always very small amount at a time. I don't believe in giving too much information at a time. It should be in chunk, not in junk. So that is really important, that how things are presented to you so that it directly hit to your mind. So these all really keep me motivating to keep doing this work, and I really feel very overwhelmed when somebody writes such good words for the sessions. And I really looking forward for the success of this July exam, for the batch we started in December. This is the first session of December, feedback, and this is really near to my heart. Now, why us? As I told you, small group teaching, quality material in a simplified way, personalized care, 24/7 assistance, daily quizzes, constant motivation to solve question, and perfect balance of reading and question solving. This is our upcoming course for the crash course for July. This is 5 days to go. It's starting on 16th. And this is the cost. This is the contact number. This is the cost and contact number. If anybody is interested, they can contact. This is the upcoming course for September batch. This is 4-month course. It's starting in May. And if you see, this is the fee, early bird discount. So if you want to give in September, you can contact here. This is the course feature for September. It's a 4-month course, including all mocks as well as the classes for difficult topics, separate classes, 3 to 4 hour classes, include the question answer solving and the end revision, which is most important, EMQs, which is most important. Why MMRCOG? Because your success is our goal. This is the upcoming course for Jan 2023. This is a 7-month mega course. The same we started for July, which is started in December. And students are really happy about starting early because they are feeling more confident from now itself. So this is the best course if you are already decided for January. So registration opened already for Jan 7-month course. If anybody is interested, they can contact here. The details of contact are here. So if you want, you can register now itself for the Jan 2023 if you are sure about that exam. And it will have a free crash course as we are having for the current batch also for the mega course. So that's all about all the courses offered till now, and the registration for Jan already started. And as I told you, September students, if you have decided for September, this is a great offer, the early bird discount of you can join the course only for $299. So it's a very good opportunity for you to revise your things and get confident for the exam. And as I told you, the crash course for the July. Okay, so we will start now with the endometrial hyperplasia GTG. So this is February 2016 GTG, GTG number 67. This is really, really important, as I told you in the beginning also. What is endometrial hyperplasia? Endometrial hyperplasia is, thank you, Shilpa, thank you, my dear. Thank you very much. So endometrial hyperplasia is an irregular proliferation of the endometrial gland with increase in gland to stroma ratio. So if you see what is hyperplasia, usually if endometrium is thick, there should be more gland and more stroma. But in endometrial hyperplasia, the gland is more. So this is abnormal. The gland to stroma ratio is increasing. So gland is more. So it is abnormal. And that is called hyperplasia and which require treatment, right? So that is what you're worried about. Now, if you see, there is a TOG in 2015, which is a very important TOG, and it should be read after this GTG, which is Postmenopausal Bleeding TOG, which is really important, and there are many questions from that TOG. So you should read that TOG after this. And in that, they are clearly mentioned about what is the simple hyperplasia, what is complex hyperplasia, and what is atypical. So if you see simple hyperplasia means gland will be more, stroma will be less, as I told you. In complex, they say that stroma will be further less. And in atypia, the nucleus will be more, nuclear to cell ratio. So nucleus will be more. So this is how endometrial hyperplasia is graded into simple, complex, and atypia. So it increases the gland to stroma. So glands are more. That is what you are worried about. That is what make it abnormal. And if you compare to proliferative, in proliferative, there will be equal ratio of gland to stroma. So this is about histopathology. That's why you diagnose endometrial hyperplasia only by histopathology. You cannot diagnose it by scan, only by thick endometrium. No. Only by histopathology you will come to know that gland is more, and then only it is endometrial hyperplasia. Now, if you see why you're worried about endometrial hyperplasia, because it leads to cancer, right? It can lead to cancer if it is atypia. Gradually, hyperplasia can become complex and atypia and then cancer. So you want to evaluate. Like you want to evaluate the cervix for CIN. You want to evaluate cervix for CIN because you don't want CIN to become a cancer. The same way you want to evaluate for hyperplasia to avoid developing the endometrial cancer and act on the right time. So endometrial cancer is the most common gynec malignancy in UK. Can I ask you, which is the most common malignancy in UK in women? If this is the most common gynec malignancy, what is the most common malignancy in women in UK?
Is it breast cancer?
Yes, it is breast cancer. Very good. So breast cancer is most common and endometrial common is most common gynec cancer in UK women. So that's why they're worried about endometrium, pre-malignant as well as malignant lesion. If you see the incidence, the hyperplasia is 3 times than the cancer. So if you detect hyperplasia and treat it, at least you have avoided the 2/3 patient to develop from the cancer. So it is 3 times more common than cancer. Most commonly, how it will present? It will present with abnormal uterine bleeding. Anything related to endometrium will present with abnormal bleeding. So abnormal uterine bleeding, heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on HRT or postmenopausal bleeding. All this could be the presentation of endometrial hyperplasia. That's why postmenopausal bleeding talk you should read with this GTG. Now, what are the risk factors? Anything which will lead to unopposed estrogen is going to lead to endometrial hyperplasia, right? Because estrogen is the one which is going to make the endometrial lining thicker and thicker and thicker, and progesterone will make it secretory, right? And then she will get period. So proliferation is the work of estrogen. So anytime if you have high estrogen in the body, then there will be endometrial hyperplasia, right? So if there is increased BMI, if increased BMI, there will be more, the androgen will be converted in the cell to estrogen. That's why that will lead to endometrial hyperplasia. So obesity is really, really an important factor for endometrial hyperplasia. Even they say that they should keep the BMI. Can all of you please switch off your mic? Yes, I can also actually hear two voices. Okay, good now? Yes, I think it's good now. So in endometrial hyperplasia, you're worried about unopposed estrogen. So if the BMI is more, even they say in the guideline that anybody has it, you should tell them, counsel them to lose the weight, and they should have the BMI of less than 30. Because obesity is a risk factor for endometrial cancer, we all know. So obesity is a risk for endometrial hyperplasia, it's connected. And if they do bariatric surgery, even they say that it will reverse back to normal, all that things. So BMI is something really, really important for endometrium hyperplasia as well as cancer. And ovulation, again, the PCOS women, they have an ovulation, again, they have unopposed estrogen too much, and the androgen also can convert to estrogen. All in all, again, it is an ovulation and no progesterone. Progesterone is ultimately the protection for endometrium to grow further, because progesterone will make it secretory and then it will shed. So proliferation, to stop the proliferation, you have to have progesterone. And ovulation means no progesterone, so it is bad. So anovulation in PCO can lead to endometrial hyperplasia. So they say that if the endometrial thickness is less than 7 mm, you're safe. But if a woman of PCOS come to you with abnormal bleeding and you find the thickness more than 7 mm, then you should take the biopsy. Because more than 7 mm is not safe. Less than 7 mm means the chances of having hyperplasia is very less. So that is important. Estrogen secreting ovarian tumor, this you will get to know by scan. So once you do the scan, if you see any ovarian tumor, any ovarian mass, you should think about granulosa cell tumor, because granulosa cell tumor has 40% association with hyperplasia. So they secrete the estrogen, and the marker is inhibin, which is also a common exam question. So granulosa cell tumor has secretion of hormone, which lead to thick endometrium, and that can lead to later cancer. So estrogen secreting tumor is really, really important. Now, drug-induced endometrial stimulation means she might be on HRT, estrogen replacement therapy. She might be on anti-breast cancer drugs like tamoxifen, which can lead to thick endometrium and polyp and cancer. So all this drug-induced stimulation also you have to keep in mind. So whenever a woman come to you with an endometrial hyperplasia, first of all, you should look for what all factors are there which are making her high risk, like BMI, which is modifiable, like drugs, which are modifiable factor. PCO, you cannot change it. She has PCO, she has it. So that's it. Immunosuppression and infection also, they say that increase the risk of hyperplasia. So all these are the risk factor for hyperplasia, which you have to keep in mind when you are evaluating a woman with hyperplasia. Now, what are the types? What is the classification? If you see, the classification is two groups. Earlier, there was simple, complex, this, that. Nowadays, only two classification, hyperplasia without atypia and atypia with atypia, atypical hyperplasia. So only two groups are there now. This is according to the 2014 WHO classification, and this is the newest one. So how you'll diagnose? If you get any women with abnormal bleeding, abnormal uterine bleeding, you will diagnose. How you will diagnose endometrial hyperplasia? By histopathology. We already discussed it. So what you will do, how you will get the sample, you will get by taking the endometrial biopsy, right? So either you'll take the biopsy in OPD, you can take it in OPD simply by pipple, or the next step will be, you can, if you are not able to take from pipple, you can do by hysteroscopy biopsy in OPD. Or if that is also not possible, you will do inpatient hysteroscopy and biopsy. So these are the three modalities by which you can take the sample for histopathology for endometrium. Now, hysteroscopy and biopsy when? Usually you will take pipple, right? Usually you will take pipple because that is the simple thing. Or if needed, if you are failing in that, if your outpatient sampling failed, means pipple failed, or if you took the sampling from pipple which is non-diagnostic, means it's not enough sample or something, you are not getting any idea, then ultimately you have to go to your next step, which is hysteroscopy biopsy. So either you failed with outpatient sampling, or if you see any polyp, any mass lesion, if any mass lesion you are seeing, you have to do hysteroscopy always. Even in HMB guideline, you will see that if any mass lesion you are seeing or symptoms of mass lesion, you have to choose hysteroscopy directly over the scan. Even you will not do scan, but directly go for hysteroscopy. So it's very important. So hypoplegia within a polyp, that is a very significant thing because you have to do the hysteroscopy and you have to take the sample from the baseline endometrium. You will take the sample from polyp as well as the baseline endometrium. We will see that later, and that is also a famous recall question. So that's important. If you see any focal lesion, you have to do hysteroscopy. I made it clear already. And if the bleeding persists, why you are taking if the bleeding persists? You took a pupil sampling and it came non-hyperplasia or whatsoever, normal proliferative endometrium. And then if your bleeding persists, if the person is coming to you again and again with abnormal uterine bleeding and you took the pupil, it is negative, what you should do? So you should go for the next step, which is hysteroscopy and biopsy, because they say that 2% of the time, even despite negative biopsy, you may have hyperplasia. Because every investigation, everything has its own limitation. You cannot 100% diagnose by any investigation anything. So always there is a loophole, always there is a chance of missing. So if anybody persists with some same problem again and again, and your first evaluation is normal, then you always go to the second line investigation. So this is a second line investigation for if bleeding persists. So these are the indication of hysteroscopy biopsy. This is very important because in exam, they will give you a question where they will give you some of this scenario and they will ask you what you will do next. So you will choose hysteroscopy biopsy in that scenario, because investigation is what they always ask you in exam, that what next investigation you will plan for that woman. What will be the investigation pattern? How good you know about which investigation first and which next. So investigation, you have to be really thorough in gynae, all the topics about the sequelae of investigation, how you move forward to second line. If you see hysteroscopy, it is more accurate in detecting the diseases rather than ruling out. That means if you see an abnormal hysteroscopy thing, it is going to help you in diagnosing things, like diagnosing cancer. They say that hysteroscopy is good at diagnosing cancer rather than hyperplasia, because hyperplasia will not show much of changes in hysteroscopy, maybe a little more vascular. But if you see a fungating mass or something, it's for sure short cancer. So cancer hysteroscopy can diagnose better than hyperplasia, and it is good at detecting rather than ruling out. Ruling out means if hysteroscopy is normal, you cannot say that she has no problem. That is not 100%. Anything is not 100%, but abnormal is more reliable rather than normal excluding the abnormality is what they want to say. The other investigation, TVS and CT, MRI, all these things, biomarkers. So if you see, TVS, you may use some time in pre and postmenopausal women. Why you are doing TVS is you will get an idea about if any focal lesion are there in the endometrium, as well as you will see the ovaries. There could be association with the ovary. We saw that there could be granulosa cell tumor in the ovary. There could be some other things in the ovary, cyst in the ovary, anything. So you have to look for the ovaries also, because even they say that 4% of the time with the TPR, there could be ovarian cancer. So you want to look for the adenic cells. So it helps in ruling out the ovarian thing, one thing. And the other will be the endometrial lining, polyp, any mass lesion you will be able to look for in TVS. Now CT, MRI, biomarker, they not routinely recommend because they say that it is not needed. It doesn't make a difference because your main investigation and diagnosis is by this. So no need routinely to do all these things. How you will manage, very important, how you will manage each and everything. Believe me, every line of this guideline is coming in exam. Every line has come till now in exam. So even I cannot say that anything has not come. Everything has come in exam. So this guideline is from the beginning till end is recall. So endometrial hyperplasia without a TPR, how you will manage? Without a TPR means there is no atypical cell, you are happy. You are happy there is no atypia. But still there is a risk to progress to cancer. How much is the risk? They say less than 5% over 20 years. Very important. How much? Still it is not zero, right? Even there is no atypia, still it is not zero. It is less than 5% over 20 years. Quite a long time, but still something is there. So you have to evaluate. You have to keep evaluating the women. This is what is the message you are getting. Even they say that with simple it is less than 1% and with complex it is less than 3% in guideline. So definitely it is less than 5% over 20 years. This is also a recall thing. How you will treat it? How you will treat it? We already know the risk factors, right? Obesity, we know she might be on drugs. So first you will look for anything is there which you can reverse, like she can lose weight, like she can stop the drug which is making the endometrial hyperplasia, like tamoxifen, like HRT, all that things. So you will look for if you can reverse the thing. If you can reverse the thing, you will first reverse the thing and see. If you reverse the reason you have removed, automatically she'll remove the hyperplasia also. So if you have removed the reason, already you are done. So reversal of the risk factor will be your treatment of choice if you find any. If you don't find anything modifiable risk factor, if you don't find, then you can do observation alone with follow-up also, or you can do progesterone treatment. So you will offer her both the treatment. Either we will just observe you, or we can give you progesterone treatment. So why not all the women to be observed? Because the chances of regression will be more with progesterone treatment. So that's why you want to give them the treatment. So if they fail to regress with observation, or if they are symptomatic women, you want to give them progesterone treatment. If she's symptomatic, you will not tell her, go home and relax, it will reverse. She wants some treatment, right? So any symptomatic women you have to treat, so you will give. And if she choose observation, like if it was an incidental finding and she chose observation, and after that you evaluated her and it has not regressed, then again you have to give her progesterone treatment. So it's important for you to understand that all these are the possibility in the management. If you see simple hyperplasia, if you don't do anything, regression to normal will be 74%. So three-fourths are already regressing. So it's a good thing. 17% will persist and 9% will progress to atypical. So quite a significant thing, isn't it? 1 in 10 approximately will progress to atypical, which we don't want. We are unhappy about that. So that's why it's better that you treat them. But if she choose observation, it will not be wrong for you to choose that option in exam, because she might choose observation and you can choose observation with follow-up for a woman if she is not a high risk. So this is how the simple hyperplasia behave. Now what about progesterone treatment? So progesterone treatment will lead to higher regression, as I told you, 89 to 96%. Very good. Approximately 90 to 95%, if you say, it's a very good thing. While we saw, if you only observe 74%, so 3/4, and it is almost going up till 100%. Even in the TOG of postmenopausal bleeding, they have given 100% with levonorgestrel. So it can go up till 100%, and it is only 3/4 will with observation. That's why you want to treat with progesterone treatment. What will be your first line medical treatment? LNG. Why LNG and not oral progesterone? Can anybody tell me that?
Local effect?
It's locally acting.
So what? Even if I need the medication, even if I put diclofenac suppository for the women, she will get pain relief. Even I will give her oral, she will get pain relief. So I should always choose suppository. Oral is more convenient for the women to take.
Fast metabolism.
She's received the dose.
Higher success rate.
Really, you people went up till physiology and pharmacology. Very good. Very active brains today. The reason is, they say that oral progesterone, see, they must have tried both. They have tried LNG, they have tried oral, but they say that oral progesterone lead to less regression compared to LNG. So LNG will lead to more regression. One thing, the percentage will be higher with LNG compared to oral. And the second thing is, if you put Mirena, you will put it, and if the women will agree, you will continue it, right? You will continue even beyond 6 months, because the minimum treatment is 6 months. It's not more than 6 months, Shilpa. It's at least 6 months. You have to give at least 6 months. But you will counsel the women that if you want to keep it, you can keep it. Because if she will take the treatment for 6 months and stop it, then there are chances of relapse. So in that case, I would like to ask you, Shilpa, how much is the relapse rate? If you will give not more than 6 months, yani if you will give only for 6 months, it will not relapse. It can relapse, right? If she has some high risk factor, she develops, she will have relapse. So you have given 6-month treatment and you stop. Okay, my dear, no problem. So if you will stop the treatment in 6 months, there are chances of relapse, and the chances of relapse is up till 1/3, 33%. Overall, they have written, different studies have said different percentage, but overall they have written in high risk women like more than 35 years of age, more than 35 BMI, or if you stop the treatment, it can go up till 33%. So please remember 1/3 after stopping. If you give her oral, you cannot give her for a longer time. At max, if she will take for 6 months and then she will stop, she can get it again. So LNG, one other benefit is it will stay for 5 years. If you will counsel her and you will tell that there could be relapse, if you want to keep it, you keep it, because initial 6 months only LNG is troubling. After that, the bleeding problems and all settles. So they say that adverse effect profile also and bleeding pattern also is better with LNG. So side effect is better with LNG rather than oral, one thing. So any women using the medication or anything, they don't want side effect. So side effect wise, it is better. Effectivity more, that is also better. And continuation, if she continue, relapse will be less. So all in all, LNG is a win-win situation. Yes, and LNG will provide contraception also, very good. So these all are the benefit of LNG. So that's why they say that this is first line and not the oral. Because they say that if you give her oral and treat her with oral, even you have to do further follow-ups. You have to keep doing biopsy yearly. While with LNG, 2 negative biopsy 6 monthly is enough. While with oral, you have to do lifelong biopsy because with oral, they are not relying on it. So you have to understand that LNG is quite effective and there are many benefits of LNG over oral progesterone. It may reduce the risk of progression to cancer and need of hysterectomy. They have mentioned it clearly in the guidelines. So you have to remember it that if you give the women LNG for endometrial hyperplasia without a TPR, you will regress her risk of developing cancer as well as reduce the risk of hysterectomy, and you can avoid the major surgery for her. So it's a good thing. So this is all about without a TPR management, how you'll deal with them, what are the possible options with you. Now we'll see the detail of how the medical management will be given and how we will follow up. So we saw that it should be first line. We know the reason now. They say that other option could be continuous progesterone, not the cyclical one. So don't choose, never ever choose cyclical progesterone. It will be continuous progesterone from every day. Continuous means anything every day. There will be no gaps. So like LNG is every day there inside the uterus, the same way continuous progesterone means it will be every day. It will not be day 5 to 25 or day 15 to 25. No, that is not a treatment for hypoplegia. So continuous is the word you have to remember. How much you will give? 10 to 20 milligram per day, or norethistron 10 to 15. So here they have mentioned when you will give continuous, only when they will decline LNG, because LNG is first line. So always you want to give them the first line. If they will say that no, I don't want LNG, or if she has a contraindication of putting the IUCD, in that scenario, you will give her continuous progesterone. How long you will give? At least 6 months. So minimum of 6 months you have to give. Either you give oral or LNG. Supposedly, she tells that I don't want to continue the Mirena, I want to remove after 6 months. So it's okay. Let her at least use Mirena for 6 months because it is more effective than oral. So minimum of 6 months, you will give them the treatment. And if she doesn't want to continue, she wants to remove, you have to remove, because if she doesn't want to remove, if she wants to remove, you cannot check her from removing. So you will remove. Or if she wants fertility, you have to remove. So if you remove, then the chances of relapse will be 33%. If you want to continue, you will encourage her to continue. If her fertility is not her factor, you will tell her, please continue because it is better. Surveillance, you will do minimum 6 monthly interval, at least 2 sample negative is what you want. So 2 sample negative you have got. Now what? Tell her tata bye-bye. Now you are no more at risk. Nothing. You can do that, but not for the high-risk women. So which are the high-risk women? If her BMI is 35 or more, or if you have given oral. So as I told you, with oral, the follow-up is different. You have to do follow-up forever annually. And if her BMI is 35 or more, she's always at risk. So you have to do follow-up annually. So this is what the follow-up differs with high-risk category. So this is all about the medical management, and every line of it is important, believe me. Now, surgical treatment, we know that hysterectomy will not be our first line treatment because LNG is our first line treatment. So when we will do hysterectomy? This is the most common recall question. When you will do hysterectomy for without a TPA? Without a TPA, when to do hysterectomy? Very important, right? So if you see, there are 2 P's and 2 R. Okay, 2 P's if she progressed to a typical. Progressing, anything progressing means you want to treat it separately, differently. Persistence of problems. So 2 P's, progression and persistence, and 2 R, no regression in histopathology after 12 months. So 1 year you have waited. You have waited 1 year and there is no regression. So that is not a good thing. So you want to remove the uterus. No regression or relapse of hypoplegia after completing treatment. So 2R, regression and relapse, 2P, progression and persistence. And the other thing is if she doesn't want monitoring, because you want to give her monitoring, you want to monitor her 6 monthly, she'll tell that, no, I don't want to come to you again every 6 months. Then in that case, you will not offer her medical treatment. If she cannot come for follow-up, you will not give her medical, because follow-up is very important, because making sure that her hypoplegia is regressed is very important, because less than 5% will progress to cancer over 20 years. You don't want anybody to progress to that. So you have to monitor. Am I clear about the hysterectomy indications? Two P's, 2R, and 1 is women declining the follow. So you will never forget. So you know now that sometimes you have to do hysterectomy. So how you will do? Can anybody tell me how you will do hysterectomy? Shall I do abdominal hysterectomy or laparoscopy? Shall I
Laparoscopic hysterectomy.
do total or subtotal? What should I do?
Total abdominal hysterectomy
Yes.
with
Shall I remove the ovaries or not?
BSO, yes. But it is, we can individualize.
TAH with BSO. So I will do laparoscopy, TAH and BSO, right?
Yeah, but BSO, not in all cases, we can individualize it.
How? For whom I should remove the ovary and for whom I should keep it?
Like if very young patient and she wants, she doesn't give consent about oophorectomy.
Very
then,
young. What is the meaning of very young? 20 year, 30 year?
Below 30, I think.
Below 30. Okay. So if you think that if less than 30 year and she doesn't give consent, anyways, you cannot remove. Even a postmenopausal woman doesn't give you to consent to remove the ovary, you cannot remove. So not giving consent is a technical thing where you will not do anything anyways. So that is a different thing. But protocol wise, if you get a postmenopausal women, you should do TAH with BSO. Laparoscopy is always a preferred one because quicker recovery, and this is not a cancer and you don't have to do extensive hysterectomy. You just have to do the simple one. Now, will I be doing subtotal or total hysterectomy?
I think total hysterectomy, but this for BSO, they say that there is a small risk of ovarian cancer, so better to remove it. That's why you individualize. But for a hysterectomy, you have to do total abdominal hysterectomy.
Yes, very good, my dear. Yes, there could be ovarian pathology associated with it. So you might have to do the ovarian removal, but in premenopausal women, it is not recommended. So for postmenopausal women, you will do TH with BSO and LAP is preferred. For premenopausal, you have to individualize, means decision to remove will be after discussion with the women. So bilateral salpingectomy is what you are going to do, because salpingectomy nowadays, anytime you do hysterectomy, you have to remove the tubes, because they say tube is the initial starting point for the ovarian cancer. So salpingectomy will always be there. So in exam, they are not going to give you the individualized option. So for premenopausal women, you will choose TAH with bilateral salpingectomy, and for postmenopausal, you will choose TAH with BSO. If they give you individualized, which is very less likely because they never give it like that, you can choose that. So am I clear about when you will remove the ovary and when not? In premenopausal, you will not remove, only remove the tube. In postmenopausal, remove it. And always laparoscopy. Now, what all you will not do? You will not do supracervical hysterectomy. So always total hysterectomy and no endometrial ablation, because if you do ablation, you cannot do further sampling. So you're destroying the endometrium and you cannot do further follow-up. So it is like closing your eyes and you don't know later she'll develop cancer. So endometrial ablation is never a treatment for endometrial hyperplasia, even without a TPA, even with a TPA. So never ever choose endometrial ablation for hyperplasia. Very clear. No endometrial ablation, no subtotal hysterectomy, and always prefer laparoscopy. Even they say laparoscopy for first stage endometrial cancer. So for this hyperplasia, definitely you don't have to do open surgery. Lap is enough. Now, risk of progression to cancer, the most favorite question of exam. Endometrial hyperplasia without atypia, we already saw. With atypia, they say overall 23%, but with complex, it goes up till 29%. So 30%. So this is usually asked, complex how much? So 30%. Coexisting cancer, if you find an endometrial hyperplasia with atypia, coexisting cancer could be there. Already, if you find an atypia, already there could be endometrial cancer in 43%. Very high, isn't it? With atypia, you found atypia and you see 43% are already having the cancer. So it's quite high. That's why the treatment of choice is always hysterectomy. Coexisting endometrial 43%, ovarian 4%. These all are recall question. Progression to more than stage 1, because usually it will be early stage cancer, but more than stage 1 will be less, only 2%, and metastatic disease will be 0.5%. So thankfully these are less. The advanced cancer are less, but stage 1 could be there up till 43%. Very important for you to memorize this all percentage. How you'll manage? So we saw for without atypia, you are going to simply do the Miranda. And if you get 2R, 2P or women decline, you are going to do hysterectomy, which is laparoscopically. Now for atypia, what will be your first choice? Why our first choice is hysterectomy? Because there could be coexisting cancer already. So first line treatment will be total hysterectomy, as there are chances of progression also quite high. So you want to do the hysterectomy. So you did total hysterectomy. How? The principle will be same, what we already saw for the without atypia. But you will not do frozen section analysis. You will not do routine lymphadenectomy, because at max it will be having stage 1. And stage 1 will usually not go to the lymph node. So no need of doing this extravagant thing of extra precaution and extra monitoring, no need. No frozen section, no routine lymphadenectomy for the atypical hyperplasia. Now, if they want to preserve the fertility, you cannot remove their uterus. So definitely you have to opt for something else. Or if they are not suitable for surgery, unfit for surgery, you have to opt for something else. So what you will do, you will counsel them that there is a risk of progression. There could be coexisting cancer, all these things you have to counsel her. You have to do some extra investigation to make sure that you are not missing any coexisting cancer already. So what you will do for that, you will do MRI, you will do CT, you will do CA125, all these things you will do to rule out ultrasound, CT, MRI, CA125, all these are extra investigation to make sure you're not dealing with cancer already. All these things will be evaluated by the MDT meeting, and then they will tell you how to manage it. First line treatment, if they cannot go for surgery, will be LNG. Again, because LNG is better than oral. So LNG will be the first line treatment. And if they refuse or whatsoever reason they cannot use it, then it will be oral. They say that if you use LNG, the risk of progression will reduce 5 times. This is also an important aspect, that if you give LNG, the risk of progression has reduced 5 times. So quite significant, isn't it? So that's why if they cannot go for surgery, give them LNG. Once fertility is no longer, all this you have done because of fertility. So once she doesn't need fertility, you will do the hysterectomy. right? Because the final treatment is hysterectomy. You don't want to take any risk with atypia. So once a fertility is no longer needed, you will go for definitive treatment, which is hysterectomy. They say that relapses will be higher in the first 2 years. And if they get, supposedly, a woman, she wants fertility, so you have given her oral progesterone because LNG is not going to allow her to become pregnant. Or you will give her LNG and you will refer her to IVF center and they will plan for IVF. So supposedly after giving LNG, you took the sample after 3 months and it is positive. So you took it again after 3 months, again it is positive. So what to do? You will tell her that we have to remove your uterus because it is not working. Or you will keep trying, or what you will do? What will be your action? Somebody needs fertility, you don't want to remove her uterus. Now she came for follow-up. You gave her LNG, she came for follow-up at 3 months. You took the biopsy, it shows positive, what to do? You took the biopsy, it shows negative, what to do?
Up to 1 year we can try, ma'am.
Up till 1 year you will try, yes, because we saw that the regression, if for without atypia, the regression doesn't happen in 1 year, you did hysterectomy. That is without atypia. What about with atypia?
I think we give her this one LNG IUS, and if it regresses a bit after one sampling, we do IVF treatment for her.
Yes, that is there. If it regresses at least one normal sample, at least disease regression should be seen in one sample before you attempt to conceive. So once you get a normal sample, you will tell her to attempt to conceive and you will refer her to fertility specialist because the IVF will give her higher live birth rate, sooner pregnancies, all that things. You want, but for you to get the atypia regression, you have to do 3 monthly 2 samples. The same like for without atypia, we did 2 samples 6 monthly. Here we will do 2 samples 3 monthly, right? This is the follow-up. If you put LNG for her, you will do 3 monthly 2 follow-up. And once you get 2 negative sample, you are happy that you got regression. Supposedly, she doesn't get regression. As you told, 1 year is what your final time you wait. If she get regression and she get relapse, what to do? She get regression and after that she again came with the symptoms and I checked again. It is relapse of hypoplegia. What should I do? Shall I give further progesterone or I should tell her no, we will do hysterectomy for you? What is the treatment of relapse in cases of atypical hypoplegia?
We have to offer a hysterectomy only, ma'am.
You cannot offer her, but she want pregnancy, she want baby.
Yeah, we are giving her what, progesterone oral, or we are giving her LNG IUS?
LNG, I gave her LNG and she
So
sampling, it was negative.
after
And she
1
tried
year,
for pregnancy, she didn't become pregnant. And then she came to me. I evaluated again, and again she's atypical. She doesn't want hysterectomy because she wants baby. Why I'm making all this story, I will tell you after that.
We can send her to a fertility specialist for having her eggs frozen. And then
that you will send anyways from the beginning. That you will send anybody who is having atypical hyperplasia and you are doing conservative management because she wants fertility. You will refer them to the IVF specialist for IVF because you want it sooner than later. You don't have much time.
So can we send her to MDT and local cancer center?
That is there. Anyways, any difficult case, you are going to send them to MDT or anyways, this is MDT only. So we are talking about MDT management only, but if anybody come with relapse and she doesn't want to remove uterus, can I try a course of progesterone again or not? This is what my question is finally.
Yes, we can try further progesterone treatment.
Yes, very good, my dear. They say that in cases of relapse also you can try with progesterone again, and there is 85% regression with progesterone in relapse. So for relapse, you can give her further progesterone, and this is also a recall question. So this is how they confuse you. What you will do? They say that if persistent, If persistent, like if I did 2 sample and it doesn't regress, then the chance of regression further by continuation is lesser, approximately 65%, compared to relapses, because once she responded, she will respond again. You get my point? So once she responded, she will respond again. Again, there will be 85% regression. If she didn't respond in the beginning, the chance of her regressing with the further treatment is further lower than relapse. So persistence is worse than relapse. Relapse means at least once she got cleared by progesterone. Second time again, she can get cleared, right?
No, ma'am. If she's having relapse, then I can give her again continue the progesterone. But what
Yes,
if she's having persistent on 2 samples? Then if it is the same, then what should we do, ma'am?
If it is persistent, you will try it further, but the chance of regression will be lesser compared to relapse. And then your
For
1
how
year
many?
target will finish, and then you will, after 1 year.
Okay. 1 year is the cutoff. Till 1 year, I can wait for her to
Yes.
respond. Okay.
Yes. So
Thank
this is what you have to understand about persistence and relapse. Once responded, again she can respond. So if they will give you in question scenario that she want fertility, she got regressed, she didn't become pregnant by that time, now again relapse, what should you do? So you can again try LNG, no problem. So relapse could be treated further by progesterone, because once responded, she will respond again. How much is the response rate? If you see regression 85%, relapse rate of 1 in 4 approximately, live birth also 1 in 4. So it's a good thing. Live birth is a good, at least 1 in 4. But relapse also 1 in 4. 26% to be, if you want to remember the figure. Disease regression should be achieved at least in 1 sample, then only she will try for conceive. Even if the endometrium is not good, she is not going to become pregnant. So if endometrial sample is showing hyperplasia, anyway, she will not become pregnant. So you want it to regress and it should become normal before she try for pregnancy. This is what the reason behind this. And always, always, always you will refer her to fertility specialist for possible IVF, because IVF has higher live birth and it will prevent. That way, the earlier it will finish, the earlier you can prevent the relapse. No problem, my dear Beena, you can leave, no problem. So this is how it goes about Atipia when you are doing conservative management. So in Atipia with conservative management, the monitoring will be more sooner, not 6 monthly, but every 3 monthly, and it will be lifelong, every 6 to 12 months. Like in without Atipia, you did yearly for only high risk group. Here you will do every 6 to 12 months till hysterectomy performed, because you have not given her first line treatment, which is hysterectomy. Till you remove her uterus, you are not going to leave her. So you'll keep monitoring her every 6 to 12 months. So sooner, half time from without Atipia. Without Atipia, 6 monthly and yearly. Here 3 monthly and 6 to 12 monthly. So please be careful about follow-up, because follow-up is their favorite question. Now, what about HRT and endometrial hyperplasia? HRT, ultimately HRT is estrogen plus progesterone, right? And sometimes it is only estrogen if there is no uterus. So whenever you give estrogen only HRT, in that cases, if the woman has a uterus, because you are giving external estrogen, there could be a hyperplasia, endometrial thickness will be more and hyperplasia and all that. So any women taking HRT, you have to counsel them that anytime if you have any unscheduled bleeding, you should come to us immediately, because we want to rule out hyperplasia, we want to rule out RTPR, cancer, anything. So HRT is a sensitive matter where you will keep monitoring if they have any abnormality. So if she's taking a sequential HRT, we will discuss the HRT in detail in the gynae session, don't worry. I'm just here giving you what is written in the hyperplasia guideline. So if she's taking sequential HRT is like she will take estrogen throughout and progesterone for only 14 days, like that, 14 days, 12 days, that is sequential. So in that case, the chances of bleeding are more, and all the bleeding scenario and problems are more with sequential HRT compared to continuous combined, where both are given from the beginning. So sequential HRT, if they come to you with endometrial hyperplasia, means they come to you with bleeding problem, you evaluated them and you did biopsy, you saw hyperplasia. What to do now? You will tell them, obviously, this is because of HRT. So do you want to stop it or you want to continue it? She will tell, no, I want to continue it. Then you will tell them, if you want to continue it, you have two options. either you change to continuous combined, because with that the risk of hypoplegia is very less, or we will change your progesterone. Rather than taking the progesterone which you are taking for the second half of cycle, you can put Mirena, because Mirena is the treatment for hypoplegia, right? So this is how you'll counsel her. Either stop HRT all throughout, or if she wants to continue, either change to continuous combined or give Mirena as a progesterone supplement with estrogen HRT. So this is what you will do with sequential. What you'll do with continuous combined, again, you will ask her, do you want to continue? She will say yes. If she wants to continue, then again, you have to use Mirena for the progesterone. So that way, automatically, you have done the treatment for hypoplegia as well as prevention for further relapses and hypoplegia. So this is how you should treat HRT with hypoplegia. The cutoff of endometrium for HRT is 8 mm. If it is 8 mm or more, you are going to take hysteroscopy biopsy, not the pipil one. Be careful about that. Always they ask you when to take pipil biopsy and when to take hysteroscopy biopsy. So with endometrial hyperplasia and HRT as well as tamoxifen, you are always going to do hysteroscopy biopsy, not the pipil one. And the cutoff is 8 mm for both. Now with tamoxifen, always their favorite question. Tamoxifen is their most favorite drug, I think. So if a woman is taking tamoxifen, there is increased risk of hypoplegia and cancer, because tamoxifen is what actually it works some places anti-estrogen and some places pro-estrogen. So at breast is anti-estrogen, so you are giving for breast cancer treatment, while in uterus it is pro-estrogen, so it leads to increased endometrial thickness and cancer. So you will tell them that if you have any abnormal bleeding, please come to us, tell us, and all this problem of her will depend upon dose and duration. The more the dose, more the problem, more the duration, more the problem. Because they say that the thickness increase approximately 0.75 mm per year. So it increases gradually. The duration is important. Also, the age of the women is important. If you see, it is the risk of cancer only in women who is more than equal to 50 years. So this is important. If less than 50, you are not worried with tamoxifen, but 50 or more, you are worried. You are worried with longer duration and bigger doses. If they develop hyperplasia with tamoxifen, what to do? As I told you, they will come to you. Any asymptomatic women, you are not going to monitor, even with HRT, even with tamoxifen. Asymptomatic women, you are not going to monitor. They will come to you with bleeding problem. You will do scan. You will find the thickness 8 mm. You are going to do hysteroscopy biopsy. So if the thickness is 8 mm, you will do hysteroscopy and biopsy always. No pipil for these two situations. Will you put Mirena to prevent the hypoplegia, polyp, cancer? The answer is no. You will not routinely use Mirena for prevention of endometrial pathology, because the role of Mirena in cases of breast cancer is not clear. So you cannot routinely use Mirena. But yes, if you find she has hypoplegia and polyp and all that, you can treat her with Mirena for that duration. So Mirena is going to reduce the polyp and hyperplasia for sure, but routinely you are not going to use it for prevention. But for treatment you can use. But all this will be with the multidisciplinary team discussion. And always you will ask her if with tamoxifen she has hyperplasia. Definitely the expert, the oncologist will evaluate her. Does she need tamoxifen to be continued? Because you are treating for one cancer and we are developing another cancer. So is it really important now to continue, or she can discontinue? So that all things has to be discussed in the multidisciplinary meeting. And always you have to take hysteroscopy biopsy, and LNG is the treatment. But for prevention, you will not give LNG, because still the evidence is not enough and not clear. If they are taking aromatase inhibitor like an estrozole and letrozole and all these things, there is no risk of hyperplasia and cancer, so they can safely use this aromatase inhibitor. So maybe if they are taking tamoxifen, you can change them to this, because this aromatase inhibitor doesn't have the risk of hyperplasia and cancer. They are not pro at uterus. Even at uterus also they are anti-estrogen, so they are safe for endometrial hyperplasia and cancer. Am I clear about tamoxifen? This is really, really important. All the aspect of tamoxifen with endometrium. Okay, good. Now, the most important other exam question is polyp. If you find a polyp, if you find hypoplegia in the polyp, what you should do? They will give you a scenario. You did a polyp removal and you found it is endometrial hyperplasia. So what you should do next? So you should do next is hysteroscopy biopsy. Why you should do that? You should do that because 52% of the women will have hyperplasia. Whenever they have hyperplasia in the polyp, they will have hyperplasia in the endometrium. So it's important that you take the endometrial sampling, get to know is it atypia, without atypia, with atypia, and accordingly you have to treat. So it's very important that you go back, do hysteroscopy, and do the endometrial sampling from the area other than polyp. Am I clear about this? Are you clear about this? This is really important, and this is really a significant exam question. So if you get a polyp, always the baseline endometrial evaluation is important because it might be atypia. If it is atypia, you might have to go for hysterectomy. So this is all important. So this is a master chart. Again, here they are talking about one thing is follow-up, like with atypia, the follow-up is 3 monthly, and without atypia, 6 monthly follow-up. And they will keep talking to you when you have to do the hysterectomy. So do the hysterectomy here. We already discussed which all things you have to do the hysterectomy. So if you see without atypia, you have to do 6 monthly sample, and if high risk of relapse annual, here every 3 monthly, always you want 2 negative sample, and here long-term follow-up will be till hysterectomy done. This is just for revision, and this is the master chart of this guideline. So that's it. I hope I'm clear. So we will do the question practice now. Yes, anybody can read this? Who wants to read?
A 48-year-old woman presents with irregular heavy menstrual bleeding and an endometrial biopsy confirms endometrial hyperplasia without atypia. The woman has a normal BMI and only with significant past medical history is laparoscopic sterilization at the age of 35. An LNG-IUS is inserted for 6 months, after which it is removed. An endometrial biopsy at the time is normal. Subsequent biopsy 6 months later is also normal. The woman continues to have ongoing bleeding. What is the appropriate management? A. Offer endometrial ablation. B. Hysterectomy. C. Reassure and discharge. D. Reinsert the LNG-IUS and reassess after 1 year. E. Repeat the endometrial biopsy after 1 year. E, ma'am. The answer would be E, ma'am. We will repeat the endometrial biopsy.
You will repeat the endometrial biopsy after 1 year.
Because already it has been 1 year, no, ma'am.
Yes. Read it carefully again. She's a 48-year-old woman. She has irregular HMB, right? Biopsy confirmed without atypia. So what do you want to do now?
They have already given
Two
LNG-IUS.
samples 6 monthly, and it should be negative. This is what your goal is.
So she has already taken 2 samples. The 2 samples
She has a normal BMI.
Yes, ma'am.
So you did 6 months after, which is an LNG is inserted. You did the biopsy normal. Subsequent biopsy 6 months later is also normal. So your biopsy is normal, two negative sample. So why you want to evaluate her further? You don't have to evaluate without a TPA, right?
We have to offer hysterectomy.
Can you please speak up a little loudly, my dear? I cannot listen the voice, please.
Ma'am,
I'm also
we have to
shouting,
offer hysterectomy, ma'am.
Why?
She is continuing. Ongoing bleeding is there.
Ongoing bleeding is there.
Very good, my dear. So what is it? 2 P's and 2 R's, I told, right? Persistent symptom. What is the other P?
Progressing, ma'am.
Progressing. So progress, persistence. Progress and persistence. What are the 2 R's?
Relapse and no regression.
No regression and relapse. Very good. So no regression. You told me that you will evaluate after 1 year. This is only applicable to a woman who received either oral progesterone or if her BMI is more than 35.
Okay.
She has no symptom and 2 samples are negative. So you got my point, my dear, how it is
Okay,
different
yes,
than
ma'am.
what we thought. So
Yes,
because
ma'am.
here persistence of the symptom, you are going to offer her hysterectomy even if the samples are normal, because as I told you, any investigation is not 100%. So you have to believe on the clinical finding also. If she received LNG, if after 1 year 2 sample negative, then also her symptoms are there. Something somewhere is wrong which you are not able to diagnose. She is 48-year-old. No harm in removing her uterus. Okay, clear?
Ma'am.
So it will
Thank you.
improve persistence. So key is B. Believe me, this guideline when I read, believe me. I'll tell you, this is the only guideline I made notes 2 times. One time I made for the guideline, and then the postmenopausal bleeding TOG, I mixed with that and made it again one more time the notes. This I have the notes 2 times of this guideline, and then only I could remember things well and understand it well. So some guidelines are like that. Though it is not a very big guideline, but it's really very confusing. Sometimes too much information, and sometimes you are not able to relate it. So once you practice more and more, you will be more confident. Don't worry. This is just beginning. One time you have listened. Once you listen to it 2-3 times, you will not forget even a single point. Okay, next. Who wants to read this?
A 52-year-old woman with a body mass index of 32 presents with irregular vaginal bleeding. Ultrasound demonstrates a thickened endometrium, and endometrial biopsy confirms endometrial hyperplasia without atypia. LNG is inserted. What follow-up should be arranged? Follow-up. The follow-up will be, this is without atypia. So it will be endometrial biopsy at 6 and 12 months and discharge if normal. But
Okay, very
her
good.
BMI is high, so it will be 6 months and 12 months and then annually for life. This is the
What is the cutoff for annual biopsy, my dear? What is the BMI cutoff?
35, yeah, 35. It is less
35.
than 35. So the answer will be C.
Very
It
good.
is,
So
yeah,
I
less
know,
than.
and I totally agree with all of you getting confused, because as I told you, this is really a very confusing one. But you have to remember all the rules to make it correct. So very good. The answer is C, because there is no high risk factor. You have not given her oral progesterone and her BMI is less than 35. So to follow up normal, then you will discharge. Yes, next question.
A 55-year-old
Hello, ma'am.
woman.
Yes, go ahead, Dr. Gopa. And the next for you, my dear.
A 55-year-old woman presents with postmenopausal bleeding. A pupil hyperplasia is without atypia. It's explained to her that she will need to have treatment for 6 months, followed by a repeat biopsy, which treatment is most likely to result in a histologically normal endometrium after 6 months. Conservative management, continuous oral medroxyprogesterone, cyclical oral MPA, GnRH, and insertion of an LNG-IUS?
Yes, because that we know that is the best thing, and we know that is more effective than anything else. So this is the answer. Very good. Now, next. Who was the next one who wanted to read? Can read now.
What is the prevalence of postcoital bleeding? It's around 9%.
Very good, my dear. This is just a prevalence, so you can read the next question. Wait. Yes, read this one. Yes, go ahead.
24-year-old woman presented with postcoital bleeding on speculum examination. Cervix was looking hypervascular. with erosion and suspicious of cancer. All of the following are recommended investigation for her except vulvovaginal swab, it should be done, pregnancy test, cervical screening test, colposcopic assessment. Cervical screening test is not recommended if it is suspicious of cancer.
Very good. And what else?
Uh,
Most of you wrote D. I don't know why you wrote D. First of all, she is less than the age of cervical screening. So she is less than 25. So anyway, she is not for cervical screening. And if suspicion of cancer, anyway, she is not for screening. Right? So both ways, there is a clear-cut thing that she is not for screening, but for colposcopy. So you will directly refer her for colposcopy. Anyway, she has not yet the age of screening. So it was clear-cut. I didn't confuse you much here because I gave you the age 24. Very good, my dear.
Thank you.
Yes, who wants to read next?
A 55-year-old postmenopausal woman presented with post-coital bleeding on Cervical Examination. The Cervical Polyp was noted. Which of the following investigation is not recommended for her? Yes, yes. Hysteroscopy and Endometrial Biopsy, yes. Vulvovaginal swab, yes. Pregnancy test, D. In postmenopausal.
Yes, very good, my dear. Because pregnancy test is for reproductive age group. So if you see, if you have not noted this year or postmenopausal, if it didn't register in your mind, you will choose pregnancy test as always the first test to be done. So please be careful about age. As I told you, in gynae, age is very important because everything changes by age. Everything, management, everything get affected by age. So be careful about age always in gynae patients, same as infertility. Okay, yes. Who is next? Who wants to read this EMQ?
I'll read,
Yes,
ma'am.
any of you.
First, I'll read the question, ma'am.
Hmm.
Each of the women described below presents with abnormal vaginal bleeding, for which an ultrasound scan with or without an endometrial biopsy has been performed. Choose from the above option list the single best treatment option you will recommend for the patient. Each option may be chosen once more than once on record. So question 1 is, a 40-year-old woman with PCS. What is PCS? A 40-year-old woman PCS is investigated for amenorrhea of 9
Post-coital
months.
PCOS, I think. I'm sorry for this. This is PCOS. This is the typing error.
Okay, ma'am. A 40-year-old woman with PCOS is investigated for amenorrhea of 9 months duration by means of a transvaginal ultrasound scan. Her endometrium is reported to be 8 mm thick with no other abnormal findings in the uterus. So the options are A. Cyclical progesterone, B. Endometrial ablation, C.
No,
Endometrial
wait.
biopsy.
Wait, my dear. Who is this?
Charumati, ma'am.
My dear, whenever you are going to the option in EMQ, first of all, you should make your answer in your mind because you cannot read a list of 25 options and then you will finalize your answer. You will get totally confused and waste a lot of time in EMQ solving. EMQ, the first golden rule is read this, read the question, make the answer in your mind, and then look for your option here. And you will find 3-4 closer option to your option, what you thought in your mind. So please tell me what you want to do in this patient.
This patient is a case of PCOD, ma'am, and she is having amenorrhea of 9 months. Her endometrial thickness is 8 mm. So it can be a case of endometrial hyperplasia.
So what do you want to do?
I want to do a biopsy and confirm whether she is having endometrial hyperplasia.
Very good. So what is the cutoff for PCOS women for endometrial thickness where you want to evaluate?
7 mm, ma'am.
7 mm. Very good. So if it is less than, if I would have given here 6 mm, you would have not done biopsy. You get my point? Because it is 8 mm more than our cutoff. That's why we are doing biopsy. So now the answer is already in your mind. You want to do endometrial biopsy. Now search for your option, which is in your mind, to the option.
Option is C, ma'am. endometrial
So now
biopsy.
you saw how you saved your time. Now if you would have read, if I would have kept this at the end, you would have read so many answers. Your
And I
brain
would
has
have
to
got
formulate
confused.
each answer and then you will go to the last.
Okay.
So it's too much of wastage of time, and in exam you don't have so much time. So please, for EMQ, this is the rule that you have to make the answer in your mind and look for your possible answer here. And you will find 3-4 close option. You have to choose one. What is your sure of? That option you have to choose. Clear, my dear?
Yes.
Yes. Next, who wants to read the next?
A 43-year-old woman who presented with amenorrhea of 12 months had an ultrasound scan that reveals an endometrial thickness of 9 mm. She had an endometrial biopsy with PIPL, and this has been reported as hyperplasia with atypia.
So what do you want to do?
She has atypia at age of 43. So I can go for LNG and repeat the biopsy after 3 months.
What is the treatment of choice for atypia, my dear?
Hysterectomy is the treatment. Laparoscopic TLH, total laparoscopic hysterectomy.
Yes. Then why you chose LNG for her? Keep a clear-cut rule in your mind. Without atypia, LNG; with atypia, hysterectomy, for sure.
Yeah.
Until unless they confuse you more, saying that she wants fertility, she wants this, she wants that at any age. Please be clear about. Even postmenopausal women come without atypia. You're not going to do hysterectomy for that. Am I clear about that?
Yes.
The rule
Okay,
is
here.
fixed. You have to follow the rule. Like maths, 1 + 1 is 2. The same rule apply here. With atypia, you have to do hysterectomy. Without atypia, at any age, irrespective of her age, irrespective of she's menopausal or postmenopausal, you have to give her Mirena. If a 55-year-old woman come to me without atypia, what I'm going to do?
55 years without atypia. We will offer hysterectomy.
No, my dear, this is what I'm telling you. Without atypia, you will not offer a hysterectomy. Why you want to expose her to a surgery when it is not needed? Ultimately, hysterectomy is a major surgery. All hypoplegia, you are going to do hysterectomy? No need. Without atypia, the rule is Mirena. So even if she is 55-year-old postmenopausal woman, without atypia, I'm going to offer her Mirena because my first line for without atypia is Mirena. You get my point now?
Yes. Here there is no laparoscopic hysterectomy option. It is written total abdominal hysterectomy BSO, that will not be there. Frozen section will not be there. So it will be.
Yes. So
There is
what
no
is your answer?
supracervical also we will not do it.
I'm very happy I didn't give laparoscopic hysterectomy.
If
What they wrote
laparoscopic
in the
is not
guideline,
there, then we can take.
laparoscopy is preferable. That doesn't mean I don't know laparoscopy, so I will not do hysterectomy for atypia hyperplasia. I can do, right? It's laparoscopy preferable. So if in the option you will get laparoscopy, you will choose that. But if there is no laparoscopy, you can do abdominal, right? Always, if I don't know laparoscopy, I will do abdominal.
The total abdominal hysterectomy and BSO will be the answer. Yes.
Right? Usually in exam, I don't know, sometimes they might give you laparoscopy, sometimes they might not give you laparoscopy. So you have to understand what is written in the guideline. Laparoscopy preferable. They have not written that if you do total abdominal hysterectomy, it is criminal. You can do. I don't know laparoscopy, so what to do? Though I know, but
Total
if I
abdominal
don't know what
hysterectomy.
I will do. She's in a
And
remote
BS.
area where there is no laparoscopic setup. So we will not do total abdominal. We can do, right? You get
Yes.
my
The
point?
F will be the answer for that.
But you got my point, right?
Yeah,
That
I
TH is
got
not
that.
wrong.
Okay. Then.
TLH is preferable, but TH is not wrong. You got my point?
Yes.
Okay, good. So the answer is F. Yes, next question. Who wants to read?
A 50-year-old woman is seen in the clinic with irregular vaginal bleeding of 4 years duration. She reports that for the last 6 months, she has been amenorrheic. You arrange for an ultrasound scan, which shows multiple fibroids with an endometrium that measures 7 mm. An endometrial biopsy is organized, and the result reveals hyperplasia without ATPS. For hyperplasia without ATPS, and she is having symptoms, so we give her progesterone and not LNG because she has multiple fibroids. So maybe medroxyprogesterone acetate continuous.
Very good. I never thought you people will get so many confusion. I thought I have put very straightforward questions and everybody will think, what kind of question is this? Anybody can answer this. Now, this multiple fibroid is a contraindication for Mirena. What make you think that?
Because there are multiple fibroids, so there may be some fibroids could be submucous or intramural. So
question she has a submucous fibroid, right? Did I mention?
No. It's the same answer.
Then why you
Also,
assume?
Mariana is not a,
This is how we get confused. Clinically, this is how we do, right? But
yes.
What?
Mirena is not the first
Because
choice
Mirena
for
is
fibroid.
not, we shouldn't give. In a patient having fibroid, you cannot put Mirena. Is it so?
We can put, but we do not know that it is which type of fibroid. I just assume that it may be mucosal cavity distorted.
That is what I'm telling. With fibroid also, you have to understand with fibroid also. I know these all things I am talking about, but all things are interconnected. You know, anything I will teach first, the other thing will be after that. So we have not yet discussed fibroid. We have not yet discussed HMB. So once we will discuss that, you will get more clarity. But the thing is, till they don't mention anything in question, don't assume. Okay, if they want you not to choose Mirena, they will give you fibroid, submucosal fibroid. They will clear-cut give you. Clear-cut contraindication they will give you. Here they have not given means you will not assume. With fibroid sometime for HMB, you can put Mirena because fibroid might not be the reason. Maybe she is having 1 centimeter 3 fibroid in the intramural. Multiple fibroid could be 1 centimeter 3 fibroid, intramural, subserosal, anything can be there. So I can't put Mirena, I can, right? So if they want you not to choose Mirena and choose continuous progesterone, they will clearly write the contraindication of Mirena, like the fibroid in the submucosal cavity. You get my point now?
Yes,
so please be careful because believe me, gynae, if you see the topics are so much intermixing and so much confusing, and clinically we are following something else and here they are following something else. So it's really sometimes very complicated. So this basic rule, always remember that when they want you to choose some other answer rather than the routine basic first line, they will give you clear-cut contraindication of the first line. So if they give you clear-cut contraindication of first line, you will not choose that. Otherwise, always stick to your first line. Clear, all of you?
Yes,
okay, my dear. So what will be your answer?
LNG, Mirena.
Yes, and if she is 55-year-old postmenopausal woman, what will be your answer?
Still, it will be Mirena only, ma'am.
Very good. This is what I want to listen. Still, it will be Mirena because Mirena is a first-line treatment for without atypia. You don't want to remove everybody's uterus just because you think that this will avoid the follow-up and everything. They don't do it like that there. They want to follow the ideal treatment, and the ideal treatment first line is Mirena. So even the patient come to me at 75 years of age without atypia, I am going to give her Mirena only. Clear?
Yes, ma'am.
Okay, very good. Suki, CFM, you people did well. And I'm happy that we got all the possible confusion of all these questions so that we get clarity, crystal clear in our mind that how we have to manage the endometrial hyperplasia women. Once you listen to the recording 2-3 times, believe me, you will never forget all these rules. And as I told you, I made 2 times notes of this complicated guideline. Believe me, this was like the most difficult one because you have to gather the information from different places and then you have to remember. So that makes the things more challenging and difficult. So at least if I'm giving you all together everything in one place, try to memorize it well so that your time will be saved and you will be able to do all the questions right. So I hope all of you will get easier way of remembering. Any queries anybody has?
Ma'am, I have a doubt, ma'am.
Yes.
Ma'am, what if a patient has a polyp and I'm doing hysteroscopy guided biopsy? The polyp is having atypical hyperplasia, whereas the background endometrium is normal. So in that
If
case,
the
what
polyp
should I
is
do,
having
ma'am?
atypical hyperplasia also, you have to do the endometrial biopsy, my dear. Why? Because if you do endometrial biopsy, you might see cancer there. So if
The
you see,
endometrial biopsy was normal. Background endometrial biopsy is normal for the patient. In that case, what we should do, ma'am?
if the background endometrium is normal, you have done that, and polyp is showing atypical hyperplasia, then you have to follow the atypical hyperplasia protocol.
Okay. We have to still go ahead and do hysterectomy.
You have removed the polyp.
Yes, we have removed a polyp.
Actually, this is a little tricky and they shouldn't give you like this because if
Because
polyp
I
has
remember in
atypical
the last
hyperplasia and you have
exam,
removed the polyp.
I remember this question coming in the last exam, ma'am, in an SBA.
Because if you will find the endometrial normal, you should follow what you get in the background endometrium. So I think then the answer should be if you they gave endometrium normal or without atypia hyperplasia.
Normal. I don't know.
So normal proliferative endometrium in the background and the polyp is showing atypia.
Yes, ma'am. The option, the
I think I
polypectomy
will
has been
recheck it in
performed.
the endometrial polyp TOG because I'm not sure what is written there. But according to this, they say that you have to go according to the background endometrium, whatever you get. I will show you that. What they say that subsequent management should be according to the classification of hyperplasia. So if you are not getting anything in the background, you don't have to do anything ideally according to this guideline. But I will check in the endometrial polyp TOG because we have to follow now the because here there is nothing in the endometrium, so we have to follow the polyp. How you manage a polyp showing atypia. So I will check in that and I will get back to you.
Sure, ma'am. Thank you.
Because here, according to this, you have to follow whatever your background endometrium is. Please.
Okay, ma'am.
Okay, anybody else has any queries? Okay, so thank you very much for attending today. These are all the group link. If anybody is not a part of these groups, we have the Telegram group where we discuss the questions and the schedule is running and YouTube has the latest update and recording. If you have any query related to exam or anything, you can message me here and this is the email ID. Thank you very much for attending today. As soon as the recording will be ready, it will be uploaded in the YouTube so you can go through it again. But this guideline you have to remember as if you remember your 2 table. You remember 2 table even in your sleep, right? The same way you have to remember this guideline, believe me. Because from the gynae, at least 1 or 2 questions, even EMQs are from this guideline. So you have to be really thorough with it. Okay, thank you all.